Hello students, now let us learn about the antiphospholipid syndrome. Yes, APS or antiphospholipid syndrome is the currently accepted terminology for what we earlier called as antiphospholipid antibody syndrome. Let me begin by defining it. How do we define APS? The APS is defined as antibody mediated acquired thrombophilic state or acquired thrombophilia, which is characterized by two possible clinical outcomes. One is increased risk of venous or arterial thrombosis, or the second outcome is or obstetric complications. So going forward, we should definitely have a good idea about what are the antibodies we're talking about, right? And what kind of venous and arterial thrombotic events we are likely to expect in these patients, and what are the obstetric complications we are likely to see in these patients. But before we discuss about the antibodies, there is another terminology you need to be familiar with, that is CAPS. CAPS stands for catastrophic antiphospholipid syndrome, catastrophic APS. Okay, and when I say catastrophic APS, it is a form of APS or antiphospholipid syndrome where patient has developed multi-organ dysfunction syndrome or MODS involving more than or equal to 3 organs. And this MODS is due to microvascular thrombi. Then we will call it as catastrophic APS. Okay, so this is something that we need to be aware about, what is called as catastrophic APS. Okay, now talking about the epidemiology of the disease, we all clearly know that there is a female preponderance. Okay, there is a female preponderance. Females are more likely to be affected with males, and we have to remember that merely having the antiphospholipid antibodies need not mean that patient has APS. Okay, so close to 5% of general population might have one of these, one or more than one of antiphospholipid antibodies. Okay, but that doesn't mean that all the patients have a APS. Okay, then you have to also remember that 15% of recurrent obstetric complications can be attributed to APS. Okay, then you should also remember that around close to 20% of deep vein thrombosis cases can also be attributed to antiphospholipid syndrome. Okay, so the points to take home is females are more likely to be affected. You might have antibodies, and that does not qualify to be called as antiphospholipid syndrome. So you should specifically meet the classification or diagnostic criteria, and it has significant morbidity burden, right? It accounts for significant number of recurrent obstetric complications and significant number of deep vein thrombosis. And we should also remember that it accounts for up to 1/3 of cases of stroke in under 55 years of age. So stroke in young, this is one of the important causes. Okay, so this is about the epidemiology. Now talking about the antibody profile, we are talking about 3 important antibodies. Number 1 antibody is anti-cardiolipin antibody. The second antibody is anti-beta-2 glycoprotein 1 antibody, and the third antibody is lupus anticoagulant. 3 antibodies, and the first question to ask is, these antibodies are targeting which substance, right? So these antibodies are primarily targeting either the phospholipids in the cell membrane, which are negatively charged, or the plasma proteins which bind the phospholipids, right? Okay, now all these antibodies recognize which antigen? All these antibodies, all the 3 antibodies recognize the antigen beta-2 glycoprotein 1. Okay, so that is the common antigen for all of these. Then why do we have separate names for them? Okay, the reason we have separate names for them is anti-cardiolipin antibody recognizes beta-2 GB1 in presence of cardiolipin. That is why it is called as anti-cardiolipin antibody. Okay. On the other hand, the anti-beta-2 glycoprotein 1 antibody can bind the beta-2 glycoprotein 1 without cardiolipin. Okay. And the third one is lupus anticoagulant. Again, this also recognizes beta-2 glycoprotein 1, and this is associated with prolongation of PT and APTT, and this is believed to be because of inhibition of conversion of prothrombin to thrombin in assay, prothrombin to thrombin. But we have to also remember that this prolongation of PT and APTT is only in vitro. But in vivo, presence of even lupus anticoagulant is associated with increased risk of venous and arterial thrombosis. It is not associated with the reduced risk of venous and arterial thrombosis. Okay. They can also ask you the methods used for assessing these antibodies. So when you talk about anticardiolipin, obviously it is going to be ELISA. When you talk about the anti-beta-2 glycoprotein 1 antibody, again it is going to be ELISA. But for lupus anticoagulant, you can look at APTT, kaolin clotting time, and dilute Russell's Viper Venome test, DRVVT. These are the tests that we can do for. So I particularly want you to remember the test done for detection of lupus anticoagulant, right? That can be an important MCQ. Okay, so this is about the antibody profile. Now there are a few additional points I want you to know about the antibody profile. That is, the risk of thrombosis correlates with number one, presence of IgG antibodies more than IgM antibodies. So if you have IgM antibodies, you have a slightly lower risk in comparison to when you have IgG antibodies of these. Okay. And then the second thing is the titer, right? High titer is obviously associated with higher risk, right? Higher the risk, higher the titer of the antibodies, higher the risk. Okay. Then the third thing is presence of antibodies on repeated testing. So if you have antibodies on repeated testing, that also indicates that there is a higher risk of developing arterial or venous thrombosis. Clear? Okay. So these are the points we need to know about the risk of thrombosis and antibody. Now, after having understood the antibodies, let us talk about the clinical features. So far, we already know that clinical features wise, we're expecting increased risk of venous and arterial thrombosis. So when we talk about clinical features, we will be talking about involvement of the deep veins as well as arterial thrombosis and its consequences. And we will be talking about obstetric complications, right? So clinical manifestations mainly focused on arterial and venous thrombosis. And the second one is your obstetric complications. So apart from these two, there can be non-specific findings also. So Harrison gives you a nice table. If you remember the table, that is kind of adequate to answer most of the MCQs. So manifestations in terms of venous thrombosis, obviously deep vein thrombosis is the most common manifestation, right? DVT is the most common manifestation. And when we're talking about DVT, obviously lower limb DVT is going to be more common than the upper limb DVT. Okay. Other than that, the venous thrombosis can lead to development of the livedo reticularis, which is one of the common finding. Then DVT can lead to development of pulmonary embolism. Superficial thrombophlebitis is also known to occur, and thrombosis of various other sites can also occur. Question wise, they can ask you what is the most common venous thrombosis manifestation? That is your DVT. Okay. When I said other sites, you have to also include CVT among one of them. Okay. So it is the most common is DVT. Okay. When you talk about the arterial thrombosis and its related consequences, the most common manifestation is stroke, right? So for venous, the most common manifestation is DVT. For arterial, the most common manifestation is stroke. Okay. Apart from that, patients can develop the cardiac valve thickening and dysfunction, or sometimes what we call as Liebman-Sachs endocarditis. TIA can occur if stroke is occurring. TIA can occur. MI can occur, or patients can also have chronic stable angina, or there can be the risk of development of the graft thrombosis if the patient has undergone CABG. Then patients can develop leg ulcers, which are sometimes very difficult to heal or treat. Non-healing leg ulcers or digital gangrene. Arterial thrombosis of the extremities can occur. Retinal artery thrombosis presenting as blindness or amaurosis fugax. Then ischemia of the visceral organs, including the mesenteric artery ischemia and avascular necrosis of the bone and multi-infarct dementia, right? All of these are the arterial complications. But there are also neurological manifestations which are not directly related to the venous or arterial thrombosis, but they are known to occur in increased prevalence in these patients. And the number one entity we need to know is migraine. Okay, apart from that, epilepsy, chorea, cerebellar ataxia, and transverse myelopathy can occur in these patients. Okay. Now, there are also renal manifestations which can be because of complicated reasons like renal artery or renal vein or glomerular thrombosis, fibrous intima, hyperplasia, and those are known to occur. Okay. Then there can be musculoskeletal manifestations, which is basically arthralgia or arthritis. And if it is arthritis, it is usually non-erosive, right? Like you see in patients with SLE and other rheumatological disorders, not like you see in patients with rheumatoid arthritis. Obstetric manifestations, yes, I would rather consider the overall obstetric outcome. So that includes preeclampsia risk, eclampsia, and the fetal manifestations, which are nothing but obstetric outcomes. The early fetal loss, less than 10 weeks, or late fetal loss, more than 10 weeks. What we use for the diagnosis of APS is the late fetal loss, not early fetal loss. Okay. Yeah, we can use early fetal loss also, sorry. But late fetal loss gets more importance. Then premature birth among the live births. When we say premature, we're talking about birth before 34 weeks. And patients can have two important hematological manifestations, thrombocytopenia and autoimmune hemolytic anemia. Autoimmune hemolytic anemia is almost always mild. It is not clinically significant in most cases. Not clinically significant in most cases. But thrombocytopenia can be significant. Okay. So this is about the clinical manifestations. Now, how do we diagnose a case of antiphospholipid antibody syndrome? For diagnosis, we need at least one clinical manifestation and one laboratory criteria and one lab criteria. Okay, so what is a lab criteria? For lab criteria, we need presence of one of the antibodies, right? What are the antibodies we know? The antibodies we know are, number one, anti-cardiolipin antibody. Number two, anti-beta-2 GP1 antibody. And number three, lupus anticoagulant, right? Any one of these in intermediate to high titer or moderate to high titer concentration, if it is positive, and it should be positive at 2 samples drawn 12 weeks apart. 2 samples drawn 12 weeks apart. Okay, so that satisfies the lab criteria. So if you have a patient with ACL positive, then I will repeat it again after 12 weeks. If it is still positive, then that satisfies my lab criteria. For clinical criteria, any one of the clinical criteria should be met, and we are talking about either arterial or venous thrombotic events is one clinical criteria. Okay, and the second one is obstetric. And when we talk about obstetric, we need to be a little more precise. The first criteria under the obstetric is loss of or unexplained death of more than or equal to one morphologically normal fetus, after 10 weeks of gestation. That's the first criteria. Okay, that's the first obstetric criteria. Then the second one is more than or one premature delivery of morphologically normal fetus under 34 weeks of gestation. And there is a third obstetric criteria, that is more than or equal to 3 consecutive spontaneous abortions before 10 weeks of gestation. So if you're talking about 10 weeks of gestation or before that, then there should be 3 or more than 3 consecutive spontaneous abortions, like 3 or more than 3 consecutive, not like, okay, you had an intermittent or like in between 2 abortions, you had a normal delivery. No, 3 or more than 3 consecutive spontaneous abortion. But if you're talking about 10 plus weeks, even the death of more than or equal to one morphologically normal fetus, unexplained death, would qualify to be obstetric criteria. And if there is a premature delivery of one or more than one fetus before 34 weeks of gestation, that would also qualify as an obstetric criteria. So A, B, C, any one of them should be there, or even an event of arterial or venous thrombosis should be there to say clinical criteria are present. So when both are present, we will classify the case as APS, right? So for classifying the case as APS, you need these two criteria to be met. Okay, so that is about the diagnosis. Now, once we have established the diagnosis, then comes the question of management. How do we manage a case of APS? Basically, the problem here is in terms of the thrombotic risk, right? So we have to give them anticoagulants, and the anticoagulant of choice is obviously vitamin K antagonists. Okay. So if the patient has presented with even a single episode of arterial or venous thrombosis, it calls for lifelong anticoagulation using VKA. Okay. For obstetric complications, we can deal during the pregnancy period. There is no need for the lifelong anticoagulation. But for patients with the history of arterial or venous thrombosis, the anticoagulation is for lifelong. Okay. So any patient who presented with an episode of venous thrombosis should be treated with vitamin K antagonist, and the target INR in that case would be 2 to 3. That's the target INR. But if the patient presents with arterial thrombosis, then such patient should be treated with vitamin K antagonist, but the target INR here will be 3 to 4. But if you don't want to consider 3 to 4 target INR, this would be one approach. The second approach is you can give them a target INR of 2 to 3, but in that case, you are also giving them low dose aspirin, which can be anywhere between 75 to 100 milligrams per day, right? So in India, mostly we would be probably sticking with 75 milligrams. Anyway, we don't have 81 milligrams readily available in our market. So that's the approach. If there is arterial thrombosis, your target INR is 3 to 4 or 2 to 3 with low dose aspirin. Okay, so this is about arterial thrombosis. Now talking about the pregnancy related outcomes, right? So if the patient has pregnancy with history of obstetric antiphospholipid syndrome, that means right now the patient is pregnant and there is history of previous obstetric complications which can be attributed to APS, but no arterial or venous thrombosis. I have made it very clear, right? If they had an arterial or venous thrombosis, anyway, they are hooked to do vitamin K antagonists for lifetime. Yeah, another important point I forgot to tell you. Can we use newer oral anticoagulants in patients with APS? The answer is a partial no. Say, we don't prefer using the newer oral anticoagulants in these patients because studies have shown that using the newer oral anticoagulants that are associated with increased risk of arterial thrombotic events. So because of that, we are not comfortable using. But sometimes we don't have a choice. There are contraindications for use of VK. In such cases, carefully monitoring the patients, we can give them newer oral anticoagulants, but that's not the standard practice. Okay. Now, coming back to the pregnancy with history of obstetric APS, no arterial or venous thrombosis. Such patients, we treat them with low dose aspirin plus prophylactic dose of any low molecular weight heparin throughout the pregnancy. Low dose aspirin plus prophylactic low molecular weight heparin. Okay. Then the patients with pregnancy and history of thrombotic APS, they may be on the oral anticoagulants or vitamin K antagonist already by the time they are confirmed with pregnancy. We need to stop them and switch them to low molecular weight heparin and the low dose aspirin. So these patients will receive low dose aspirin plus low molecular weight heparin, but because they had history of thrombotic events, they will be receiving the therapeutic doses of low molecular weight heparin. Okay. On the other hand, those who have recurrent obstetric events despite standard treatment, like patient with the obstetric APS, he has been given the standard treatment during all previous pregnancies, prophylactic low molecular heparin and low dose aspirin. Despite that, they continue to have recurrent obstetric events like recurrent premature deliveries or recurrent spontaneous abortions or unexplained fetal deaths. In such cases, we have two options. Either we can give them low dose aspirin plus the therapeutic dose of low molecular weight heparin, or alternatively, you can also think of starting them on adding the hydroxychloroquine, or like 400 milligrams per day is the dose that we use, or we can also give them the IVIG IVIG for 5 days as infusions calculated based on patient's weight. Okay, so these are the approaches that we can follow. Now, these are all important MCQ points. So please pause the screen and memorize these points. Okay. Now, apart from this, there can be scenarios where patient is diagnosed as APS, but right now is asymptomatic. In such patients, you can give them low-dose aspirin. If there is no history of any arterial or venous thrombotic events, those patients can be treated with low-dose aspirin alone. And for patients with SLE who do not have any documented previous history of thrombotic arterial or venous events, but they have very high titers of antiphospholipid antibodies, in them also low-dose aspirin would suffice. Once they develop arterial or venous thrombotic events, obviously we will add vitamin K antagonists. So that brings me to the end of this topic. I'll connect to you on the next video with the next important topic. Till then, have a good time, guys. Thank you.